All right, good morning, everyone. Thanks for joining us today for this panel on promoting health literacy and advancing language access within the marketplaces. I'm going to be moderating today. I'm Alexa McKinley. I'm with the National Rural Health Association, but I'm going to keep my remarks short so that our speakers have plenty of time to go through their presentations. So first today, you're going to hear from Leigha Basini, who is the Director of the Division of Benefit and Marketplace Analysis and Policy at the CMS Center for Consumer Information and Insurance Oversight. And then next you'll hear a presentation from LeAnn Blanco, Health Equity Manager at the Washington Health Benefits Exchange, joined by Christine Monahan, who is an Assistant Research Professor at the Center for Health Insurance Reforms at Georgetown University's McCourt School of Public Policy. And with that, I'll just hand it right over to Leigha.
Thank you so much. It's great to be here this morning. My name is Leigha Basini. I am with the Center for Consumer Information and Insurance Oversight. My pronouns are she and her, and for those who can't see me, I am a Korean American female wearing a typical federal employee black suit. And I tried to spice it up with a colorful blouse. As you have heard, as I'm trying to get the slide to advance, which, let's see. Sorry for should have tried this beforehand. Let's see. Oops. Okay. As you heard yesterday and in this morning's plenary, CSIO is the part of CMS that is charged with implementing laws such as the Public Health Service Act, the Affordable Care Act, and the No Surprises Act. In particular, we work on policy and operations related to the health insurance marketplaces and are really proud of the enrollment that we achieved in the marketplaces for Plan Year 23. We're also really trying to do more to think about health equity in the policies that we propose and how we operationalize those policies. So I really just wanted to highlight a few of those for you today. I'm going to talk about two things. One is our sort of recently finalized standardized plan policy, which continues to evolve, and the other is a request for information that we released late last year on the essential health benefits. So first, I'll just talk a little bit about how we are trying to further health equity through our standardized plan policy, which also includes components regarding outreach with the broader community and plan display. In the summer of 21, there was an executive order regarding promoting competition, and it included a part that directed the Secretary of HHS to ensure that Americans can choose health insurance plans that meet their needs by implementing standardized plans. We saw this as a big opportunity. As some of you may know, we had previously had a policy on standardized plans, but those plans under the prior policy were not mandatory for insurers to offer, and that policy actually got phased out. So we really saw this as an opportunity to improve upon what we had done in the past. So we had to very quickly implement something, and so within a matter of about 6 months, we had held conversations with most states to get their input because these policies would be effective, in most states, and in particular those states that don't operate their own exchange. And we had to conduct research and data analysis to propose a policy, which we did in January of 22 and finalized it in May of 22. For people who are, I guess, really big health policy nerds, there is a citation there if you want to go check it out. So we ended up finalizing two sets of plans, one set for the majority of states and then the other set for some states that have unique cost-sharing laws, kind of cost-sharing parity laws, where the kind of overall, our overarching policy would have kind of frustrated those state laws. So we found that those state conversations were really helpful. And then the plans are called easy pricing plans on healthcare.gov, where people can go to do their shopping. And consumers are encouraged to kind of consider these plans when they're shopping for coverage, and they can also select to view plans with an easy pricing filter. And so we think that sort of the whole display and how consumers see these plans is very important, not just for those people who are shopping on healthcare.gov, but also people who may be using, another type of website, like a web broker website to find and search for coverage. And we think that kind of display component is really important to kind of overall consumer understanding of what it is that they're looking at and purchasing. So for the policy for this plan year, for the first time issuers are required to offer these plans. We think that these plans really help to further health equity by allowing people to make a more apples to apples comparison of plans. And so kind of the cost sharing is standardized for a key set of essential health benefits. This allows people to focus on other meaningful aspects of the plan, like the network or the formulary. So really just tries to simplify the overall kind of consumer shopping experience. The plans also offer more pre-deductible coverage. So a lot of the research and feedback that we received indicated that people prefer having obviously more coverage pre-deductible because that's easier to access without having to pay the deductible. And that people find having a fixed copay easier to understand, and it gives them more price certainty than having co-insurance. And so where possible, we favored having a fixed copay over co-insurance. The cost sharing really varies for specific services based on the metal tier and whether someone receives cost sharing reductions. But some of those copays range from nothing, for certain coverage and certain people who may be receiving cost sharing reductions. But for example, we got a lot of feedback that specialty drugs can be difficult to afford. And so we have a fixed copay for specialty drugs, $5 generics, I think at certain metal tiers. So we're trying to help give people some certainty and understanding of what it is, what their anticipated costs might look like. We also launched what we have called stakeholder transparency, outreach, and engagement, which is just an outreach effort to speak with a really broad range of affected and interested parties. Some of them are people we speak with regularly, like state insurance regulators, health insurance issuers, consumer advocates, agents, and brokers. And then we also tried to really expand the scope of the people who we were receiving feedback from. And so had a series of meetings with a lot of different people just to get their input. Oftentimes we would bring different groups together in the same kind of virtual room because we found that having that feedback and allowing people to kind of react to each other really helped to further, help us understand what people thought would be feasible and kind of in consumers' best interests. These outreach efforts are ongoing, so I think, in fact, some of the people in this room might even be part of those efforts. We recently finalized our policy for the next plan year, so for plan year 24. We updated the plan designs, so I think in proposing the plan designs for plan year 23, we really looked at the most common plan offerings, looking at enrollee weighted averages and looked at that cost sharing. I think we didn't want to be extremely disruptive to what consumers were already used to having, but really saw this as a jumping off point. So we sort of maintain that same approach for 2024 in terms of also favoring copays over coinsurance and, pre-deductible coverage. But we also continued to refine our work on plan display. I think a lot of folks may have realized that the number of plan offerings that are available to people over the years has continued to increase, such that in the final payment notice that we released earlier this year, we noted, I think that, people in some circumstances, would even have like over 100 plans to choose from. And I think, there's a whole kind of body of literature on plan choice overload and what happens when people have so many choices, they become kind of paralyzed and may in fact decide, okay, well, I don't know what to do, so I'm not even going to make a choice. I'm just going to walk away. I mean, I think we've all probably had that experience shopping online, but when it's something dealing with your health and such an important decision, we want to do what we can to make sure people aren't walking away and that people are making a choice that is right for them. So we really, did some research into choice architecture, plan choice overload, how people make shopping decisions, really tried to listen to feedback from, different affected parties, and in particular, consumer advocates who work and those who work directly with consumers, whether it's, navigators or agents and brokers. And so we ended up finalizing a cap on the number of non-standardized plans that an issuer can offer. So for 2024, issuers will need to offer the standardized plans, but they'll also be limited in the number of non-standardized plans that they can offer. There are kind of some exceptions to that based on, different factors like whether the plan offers dental and things like that. And we noted that for the 2025 policy that we would kind of propose an exceptions process. So actually for 2024, there is, we're going to be kind of like phasing in that limit of 2 plans for the 2025 plan year, along with this exceptions process that we will be proposing in future rulemaking. So, I think in terms of next steps, we are in the midst of plan certification for the 2024 plan year right now. So we were reviewing those plans, not just the plan designs for standardized plans, but also for non-standardized plans, ensuring that, that the cap will be in place for plan year 2024, and that reduced cap for 2025, and also thinking through what an exceptions process should potentially look like and what to propose in future rulemaking regarding that exceptions process. We are also continuing to work with different affected parties to gather feedback, and so that's an ongoing process as well, and we found that very helpful in in informing the policies that we propose and how we kind of approach the work in general. The other thing I wanted to talk about briefly was what we are doing around the essential health benefits. So as people probably know, the essential health benefits are the 10 categories of benefits specified in statute in the Affordable Care Act that the majority of plans in the individual and small group markets must cover. So that includes all of the plans that are sold on the marketplaces. There are a lot of other policies that kind of overlay these 10 categories of benefits. You can see some of them on the slide here. Essential health benefits have to be equal in scope to a typical employer plan. So, I think for that reason, there are a lot of differences in the different programs that CMS operates, in terms of, Medicare, Medicaid, CHIP, and the marketplaces. Benefits can't be unduly weighted towards any one category. So in other words, the benefits are trying to meet the needs of a broad population and a variety of healthcare needs. They have to take into account, and this is all in statute, the needs of a diverse population, including, as the statute says, women, children, people with disabilities, and other groups. And the benefits can't be designed in a way that discriminates based on age, disability, or expected length of life. So, something else we've done recently is finalize some new regulations regarding, non-discrimination in the essential health benefits and how benefits need to be kind of provided to people who are, trying to access them. Our current approach for EHB is using a benchmark-based approach. So each state has a different benchmark plan, and the plans in that state that meet EHB have to be substantially equal to that benchmark plan. Most of the state benchmarks are based on small group plans within the state. So again, that's kind of going back to the requirement that benefits be equal in scope to a typical employer plan. Several years ago, we updated regulations to give states additional flexibility for updating their benefits. And several states have taken us up on that opportunity. And so we are really glad to have had the chance to partner with them. There is sort of an annual cycle for states to update their benchmarks if they want to do that. And so we are in the midst of that process right now. But in the past, several states have addressed, issues going on in their state. And so it allows states to customize things a little more. I believe Illinois was the first state to do this several years ago. And several states have done things to address the opioid epidemic, to address services such as hearing aids. Last year, Colorado updated their benchmark to provide, among other things, gender-affirming care. We've seen greater coverage of habilitative services for children. So, we're really encouraged and excited about the different changes that we've seen happening in states, and always encourage states to, work with us to update their benchmarks, because it's a great way for states to target the specific needs of their population and work to, address health equity within their state, because, I think we realize that what that looks like may not be the same in every state. In addition to that, last December, we released a request for information about the essential health benefits, realizing that, at that point it was 2022. We were, several years into implementation at this point, to the point that, we had made some revisions to the policy. And so we really sought broad feedback on, a myriad of issues, including how kind of the state-federal approach has been working, whether, there's that note on the slide there about specificity of benefit descriptions, whether the descriptions in the benchmark plans are specific enough for insurers to know, kind of what their obligations are, and for states to provide technical assistance to the issuers in their states, whether the typical employer plan has changed since the statute, since the Affordable Care Act was signed into law, where there are access barriers to coverage, where there are challenges in people accessing coverage and accessing benefits, where the medical evidence has evolved and changed since the law, since we first implemented the essential health benefits. I think we want to be very proactive and be able to respond to changes and advances in medicine. And so we sought comment on examples of, changes and how we could be responsive to those changes. We talked about the need to address, different types of coverage, whether there's sufficient coverage for things like nutrition, the opioid epidemic, habilitative services for children, and then the need to address health equity and social determinants of health within EHB, and kind of how we define EHB and what the overarching EHB policy is. So we received over 700 public comments, which was, really gratifying to us, because it showed that, people are very interested and engaged in this topic. I think states really said, it's great that you've created this new path for states to update benchmark plans, but it would be also wonderful if you could make it a little bit easier. We know it's a time commitment and a financial commitment. And so, I mean, that makes us so appreciative to those states that have done it. But, understand that I'm sure there are a lot of improvements we could make. Commenters were enthusiastic about telehealth, but I think realized telehealth can both help a lot of people and it can hurt if it's not accessible to people. And so that we're really on the cusp of, thinking through what that might look like. And, there were a lot of comments about utilization management, prior approval, things like that. A lot about maternal health, substance use disorder, obesity, diabetes, a lot of the things that you've heard about, already this morning and that I'm sure you'll hear about more today and heard about yesterday. So we are still kind of going through those comments and thinking through next steps, but really appreciate everyone's engagement on these issues and are really eager to kind of dig in and look forward to the next steps with these policies and a lot of the other policies that CSIO is working on at the moment. Thank you so much.
Good morning, all. My name is Christine Monahan. I'm an assistant research professor at Georgetown University's Center on Health Insurance Reforms, which is a part of the McCourt School of Public Policy. My pronouns are she, her. I'm a white woman wearing a gray suit and brown shoes, which I Googled on the way here to make sure if that worked. The internet suggested yes, which is good because I didn't have another alternative, but I got nervous. So I'm going to present today about a forthcoming issue brief, Filling a Void, Variation in State-Based Marketplaces Language Access Policies and Practices. This is funded by the Commonwealth Fund. My co-authors were my colleagues, Jaleesa Clark and Nadia Stovacek, and I want to thank Mara Udelman at NHELP, who helped serve as an expert advisor as we worked through these issues. The Commonwealth Fund has been funding Georgetown to track what states are doing to regulate the private health insurance market and improve access, affordability, and adequacy of coverage for more than 10 years now. And we're very grateful for their support. And in particular, the past 2 years, they've enabled us to really start to dig into what states are doing to advance health equity in the commercial health insurance space. And so this report is part of that project. So as you all know, health insurance marketplaces serve a diverse population, including many people who are limited English proficient, or LEP, which means they speak English less than very well. And being LEP can create significant barriers to accessing and using health insurance. As Leigha just spoke about, think about how complex it is for those of us who speak and write in English and our native language to navigate complex health plan benefit design issues, as well as navigating eligibility rules, and now add a language barrier on top of that, and that is no small challenge. And so, we were trying to look to see what are state-based marketplaces doing to meet the needs of their LEP customers. For some context, there are obligations that apply to federal marketplaces and the state-based marketplaces, both under Section 1557 as well as in the exchange regulations. Generally, these kind of expect the marketplaces to provide language services in a timely manner and at no cost to LEP individuals. There otherwise are only a handful of very specific requirements beyond that. They must provide telephonic interpreting services in at least 150 languages. They need to provide taglines in the top 15 languages spoken by the state's LEP population on critical web content and documents. And then they need to translate website content into any non-English language spoken by LEP population that reaches 10% or more of the state population. So that's California and New York need to translate their websites into Spanish, but no obligations elsewhere. And so we wanted to see how states are kind of filling in the gaps beyond those three specific requirements and kind of maybe going above and beyond those. And so we surveyed state-based marketplaces regarding their language access policies. We received responses from 18 out of 21 states. We also conducted structured interviews with officials in 6 states to help kind of provide more context to the answers we received. And then had some back and forth correspondence just to clarify the information we received. And in doing that, we were able to get some information out of one of the 3 states that hadn't responded to the survey. The first issue I want to address is language access plans. These are documents that spell out how to provide services to individuals who are non-English speaking or have limited English proficiency. Often this can include things like a needs assessment, a description of the language services that are offered, the notices provided, how staff is trained, as well as how the organization assesses its performance. This is not currently required under federal law or regulations, and we found that only a handful of state-based marketplaces currently have a marketplace-specific language access plan. And, for when I say marketplace-specific, several state-based marketplaces are housed within a broader state agency. And so in some cases, that state agency does have a language access plan that would apply to the marketplace, but it is not necessarily tailored to marketplace operations. So things like having a navigator program or operating kind of an enrollment website. In other marketplaces, we found that some policies are written down, but they might be scattered in different places, and some things just are not written down, and it's more ad hoc. And, my impression from the interviews we did with the state-based marketplace officials is that, you really kind of get out of it what you put into it. And so for some marketplaces, their language access policy kind of sits on the shelf, kind of marks off like it's kind of a compliance activity, check the box, we did this. But for other states, and especially ones that have recently created a language access plan or that regularly update their language access plan, it's a really valuable tool. It helps the marketplaces think strategically about the needs of their population, what gaps they currently have, what are they not doing that they should be, and how they could be allocating resources effectively. We also heard that it might sound daunting to create a language access plan, but in practice it really isn't. One state that had recently adopted one was able to kind of look to other states as models and found it was a really, really helpful process for them to go through to make one. The next topic I want to cover is how states are collecting language data from their customers. And in particular, we looked at what languages are included on a marketplace application. And we found that it's not standardized across states right now. Most states do separately ask for an applicant's preferred spoken and preferred written language, but how they formulate that question will vary across states. And there are a couple states that will more generally just ask for kind of a preferred language. Only a handful of states routinely collect this information with respect to kind of other household members who are seeking coverage. And so to put that in some context, typically the applications will ask for the demographic data, including race and ethnicity information, from both the person who is kind of filling out the application, the primary point of contact, as well as any other people who will be covered by that plan pursuant to the application. So often other family members or dependents. But that section about those other family members generally did not include language as a feature. Now, despite how few states currently collect that data, my impression is that there are really good reasons to get it. From other research we've done, we know that marketplaces, will sometimes share the demographic data that they collect with the insurers. So this person who is applying got enrolled in this plan, give their demographic data to the insurer, so then the insurer has it. And it would be very valuable for them to know the language needs of all of their members. Additionally, it just simply gives you a more complete picture of your marketplace's customer base. Now, we did hear from some marketplaces about how they'll get reports from navigators or their call centers, distribution centers about the uptake in language services. And that can be important information, but you should also remember that that more closely will reflect kind of the met needs of the population rather than the unmet needs. Reports of low uptake of a certain resource might not mean that the need is actually low, but that people are not necessarily aware that it is there. I also want to recognize enrollee data is not the only source of data that a marketplace can or should use. As I mentioned at the beginning, a lot of the federal benchmarks requirements are tied to state level data. And so there may be segments of a state population who the marketplace isn't currently reaching. And so just knowing language needs of your kind of enrollees isn't going to cut it, but actually it could be really valuable to compare like who is in our marketplace, here are all the enrollees, and here's the state data. And maybe then you can see like, oh, we're missing this population. Next, I want to cover how state-based marketplaces are providing oral language assistance. One option we looked at here was having people like your call center staff, navigators, or just state-based marketplace staff themselves provide assistance in the language that your customers speak, non-English languages. Another option is to have a third party provide interpreting services, and this typically is accomplished over the telephone. As mentioned at the start, federal regulations require telephonic interpreting services be available in 150 plus languages as a floor. We generally found states do surpass this. Most reported to us that they had over 200 plus languages. That's not terribly surprising to see consistency there, since most of the marketplaces are relying on the same kind of set of vendors to provide this service. But the marketplaces did kind of report that, they see more value and lots of benefits in being able to provide services directly in the language that someone speaks rather than having to go through an interpreter. This can be more efficient rather than having a three-way conversation. You are speaking directly in the person's language, and that can help facilitate and foster trust. Many people who may be contacting a marketplace and who do not speak English as their primary language or have limited English proficiency, may have immigration issues or other reasons where they distrust the government, and bringing in a third party can just complicate that interaction. So when it came to kind of this direct in-language assistance, we found some pretty significant variation across the marketplaces. At call centers, the majority of marketplaces do report having at least one representative who could speak Spanish, but not all of them even had this, and only a small handful had representatives who were able to speak languages other than Spanish. Otherwise, it seems that states largely rely on their navigator programs to fill in this need and to employ people who can provide services in non-English languages. There, it was much more common to see navigator programs that, collectively across the state could reach 10 or 15 or even more languages. One state, you can probably guess which, was over 100. But even then, let's recognize navigators may have limited capacity or geographic scope that they service. So just having one navigator in a state who can speak Cantonese, say, does not necessarily mean that all of the marketplace customers who prefer to speak Cantonese will be able to get services. We did also hear from states about relatively creative ways to connect customers with multilingual service providers. So in one state, you can contact the marketplace and identify your preferred language and have a call back from a navigator or an agent or broker who speaks that language. In some other states you hear about, you'll kind of call the call center and then have a choice of, you can either maybe wait a little longer but speak to a call center representative in your language, or have a shorter wait time and go through an interpreter. And some states are or expressed interest in adopting some specific phone numbers for specific languages. So dial this number for Spanish, this number for French, to make it easier to connect to the languages that you need. Most marketplaces also will let you search on their website to identify navigators or agents or brokers in the languages that they provide. But this, of course, assumes that the website feature is something that the person can actually navigate and function. And so with that, I want to turn to our last set of findings regarding written translation services. Here, I recognize there are a whole lot of written materials that a marketplace is going to be putting out. We focused, for purposes of our report, on the paper applications as well as websites. For the applications, we found most, but not all, state-based marketplaces have translated their applications into Spanish, but only a small handful have gone beyond that to translate their paper applications into other languages. Websites, it's a bit more complicated. A lot of marketplaces have at least some website content translated into Spanish, sometimes other languages, and nearly half of marketplaces have a fully translated Spanish website that's available. But otherwise, kind of the scope of what is translated, what languages it is translated into, and how it is translated can vary. One of the, I think, more concerning things we picked up on is kind of the issue of human versus machine translation. And this is kind of, using a qualified translator to kind of go through line by line and, translate your document versus kind of something like Google Translate. There are a lot of concerning examples out there in the world about errors in machine translation. Sometimes the information can be grossly inaccurate, might say the opposite thing of what you are actually trying to convey. And nonetheless, we heard from several state-based marketplaces that are still using machine translation for all or a portion of their websites. in conversations, they kind of refer to this as a last resort, but ultimately they wanted to make their websites available in more languages. I think we should recognize that in some cases they may be doing more harm than good depending on the accuracy of those translations. More broadly, the quality of translations, I think, is something that is worth some further inquiry and maybe a challenge. In many marketplaces we spoke to, it sounds like the review processes can be relatively informal. Marketplaces may rely on staff members or even navigators to, who speak the language that they want material translated into to kind of take a look at the end. But these individuals may not necessarily be qualified translators or have the capacity to do this on top of their regular job duties. And there simply just may not be anyone who can do that for less common languages. And so I want to just conclude. I will say the marketplaces we spoke to universally espoused a really deep commitment to meeting the needs of their LAP customers. I think many would benefit from kind of engaging in kind of the process of creating a language access plan and really thinking strategically about the best way to put their resources forward and identifying the needs of their population more comprehensively. And to that end, I think it'd be really helpful to have more federal resources to support those efforts. Part of this might be that the federal government requires state-based marketplaces to take those first steps, the language access plan, standardizing the data that's collected, and then the states can have the information and kind of the plan to then tailor their responses, because I do recognize the needs are going to be different from state to state. But things the federal government could do to support that might be creating a lot of creating glossaries. We heard from all these states, they're all creating glossaries of these different complex health insurance terms, but they're each doing it on their own. So it seems like an opportunity for the federal government to come in and kind of help with that. Or just to create more standardized forms. IRS and FEMA have lots of translated versions of notices and other information. And so making more standardized information available that states can, they might need to make some tweaks to, reflect their local rules, but maybe if having something that's like 95% of the way there may make it easier than having to do the whole translation themselves. I think also just connecting the state-based marketplaces to be talking to each other more on this issue. I know they have lots of conversations with each other, but I think, looking specifically, convening some of those conversations on language access could be valuable, because we did see a lot of them are taking on a lot of the same steps right now. And so with all that said, I want to turn things over to LeAnn Blanco from the Washington Health Benefit Exchange. And I will note Washington really struck us as one of the leading states out there when we were doing this work. And I think they are a great model for other marketplaces. So I'm really excited to hear from LeAnn about what they're doing.
Awesome. Oh, I went too far, giving you too much highlights. All right. So as Christine alluded, I'm LeAnn Blanco. I am the Health Equity Manager at the Washington Health Benefit Exchange. Super happy to be here today. I have on a burnt orange, I think, coat because I am cold, and a black flowery shirt. I identify as Latina, Mexican American, light skin privileged, and yeah, I am super glad to be here. So, language access plan, yes, super beneficial. And as Christine alluded to, I'm going to share the journey that we took in order to create the language access plan. And first off, I just want to acknowledge that, this wouldn't have been possible had it not been for the partnership and collaboration across the state agencies and internally with our stakeholders as well as our community voices. So the purpose of the language access plan is to promote effective communication with our limited English proficient individuals. And the plan describes how the exchange makes reasonable efforts, I would say intentional efforts, to eliminate English proficient barriers to accessing the exchange's programs and activities. So this includes utilizing proven strategies to address language disparities, including, as Christine alluded to as well, the use of qualified language service providers, written translations, multimedia approaches, and other tools such as taglines that include the availability of language services. And I probably should let you see the slides along with that. So that is our language access plan, and I hope that these slides will be available to you all afterwards as well. So why did we do this? I would say that not only do we know that there is limited English proficiency across Washington State, but we have a significant growth in Washington State. And over 500,000 residents are limited English proficient. The growth population of the residents of Washington State, most of that population is going to or has experienced health disparities, more so than other residents of Washington State. So individuals who primarily speak a language other than English are less likely to have insurance, to see their healthcare provider, and even to just follow instructions post medical care. And so due to this is our why. Our why is to increase access and utilization of those services to reduce disparities that exist among this population. So what did our journey look like? I'd love to say that it was an easy journey. And as I mentioned, it wouldn't be possible without all of the collaboration and partnership across our state agencies, our community voices, our lead organizations, our navigators, assisters, and much help from our internal departments and our employees, our people. In recognition of the impact of the language barriers on access to insurance coverage and care, the exchange staff began a series of meetings with limited English proficient stakeholders. That included, many of our lead organizations who work directly with our communities, and also community members themselves, internal employees who were also identified as stakeholders and or community members that either are firsthand experiencing limited English proficiency through family or themselves. And so lots of voices were included as a part of this process. So in January of 2013, the exchange staff shared with the board for the exchange how limited English proficient individuals would be able to access programs and services during the inaugural open enrollment periods. And this included, the Exchange Health Plan Finder is what we call it, Washington Health Plan Finder, would be available in English and Spanish. Spanish is one of our larger populations that Washington State has. The application and customer correspondence would be available both hard copy and online in 8 languages, including English, Cambodian, Chinese, Korean, Laotian, Russian, Somali, Spanish, and Vietnamese. And then likewise, taglines would be available indicating the availability of language services at no cost in those same 8 languages. And then in February of 2013, the Exchange Board created, in addition to this journey, the Health Equity Technical Advisory Committee. And this was to aid in the development of the language access plan and to provide expertise and experience and professional perspective on the language access plan, as well as the community themselves. So the Health Equity Technical Advisory Committee. This, I would say, in the journey is such a significant element of being able to really partner and collaborate with community and be inclusive of the voices of the community. Our Technical Advisory Committee consists of 13 members. They all represent either a lead organization or an organization in which we partner very closely with across the state of Washington. Their voices are one of our main contributors to how we advance equity in Washington State. And a part of the development of the language access plan led to the board acknowledging the need for a very robust way for us to provide that feedback and to influence how we create and how we advance health equity in Washington State. And so those 13 members serve one-year increments. They go through a process of nomination, and then we always invite them to serve more than 1 year, but we always accept and want to make sure that we are getting voices from across the state of Washington. So they change out. And their organizations and their names can be found on our website. Super grateful for all of them and their voices as we continue to advance health equity. So with the language access plan, like all programs, plans, and processes, we want to make sure that we are being accountable, committed, and transparent in these processes. And so we have a very robust performance measure and evaluation set up for the language access plan. This happens once every 2 years and or more often when needed. And as a part of this, it's to ensure the scope and the nature of the language assistance services, provide and reflect the needs of the community of our limited English proficient populations. The exchange has a process for customers to submit concerns, challenges, complaints, even in issues related to language access, including a point of contact for facilitating resolution. The exchange reviews and addresses feedback and complaints received from individuals with limited English proficiency and interested stakeholders with respect to language assistance services and products provided by the exchange in a timely manner. Language access related feedback, complaints, and improvements are regularly shared with the Health Equity Technical Advisory Committee so that we can ensure that whatever we do in order to address those concerns, that we are implementing them with consideration of how the impact will be for that population. So it's a very intentional process. Language access related, the exchange also monitors the effectiveness of language assistance services using Washington Health Plan Finder and our CSC metrics and equity related benchmarks established by the Technical Advisory Committee, and then additional methods for monitoring the effectiveness of the language assistance service may include reviewing available data and community demographics and needs and observing interactions with limited English proficient individuals. So with that, I will share as a part of performance and measurements and evaluation, the board was very intentional with the voices on our Health Equity Technical Advisory Committee to establish a equity statement, which you can also find on our Washington Health Plan Finder website. And so I am happy to read the statement for those who are unable to, but I will say as we advance and as we grow and mature health equity in Washington State, equity is a fundamental pillar of ours. And so it reads as this: equity is a fundamental pillar to the society we seek to build. The process of advancing toward equity will be disruptive and demands vigilance, dismantling deeply entrenched systems of privilege and oppression. We must focus our efforts on people and places where needs are greatest, especially communities of color, and go beyond remedying a particular inequity to address all determinants of health. Our goal is that all Washingtonians have full and equal access to opportunities, power, and resources to achieve their full potential. So with that, I will, with my slides, there are resources, links that you can access, and always happy to continue conversations afterwards as well. Thank you.
All right, thank you everyone for joining this session, and thank you to Leigha, Christine, and LeAnn for your great presentations. We are a little over and are trying to end around 11:45, and we're like 3 minutes over, so we're going to cut Q&A, but I know our speakers would be happy to chat throughout the conference, and their contact information can be found on the slide. So join me in thanking them again.